All right, good afternoon, everybody. Can you hear us okay in the back? Because up here it's hard. Okay, so welcome to this afternoon session. I'm Dr. Tom Selva, the Chief Medical Information Officer for MU Healthcare, and...
Hi, everyone. I'm Seth Katz. I'm an Associate Administrator at Truman Medical Centers in Kansas City.
So we know that we're the last thing between you and either dinner or the magical evening with Harry Potter. So thanks for showing up. We hope this is worthwhile to you.
And there's booze outside.
Yes, and there's alcohol right outside the door. So, but it doesn't open until 5, so don't leave too early. So this is going to be very much a give and take presentation. Go ahead and go to the next one there. We'll get past that. We have no conflicts of interest. We're not getting paid by anybody to do this. So,
but we do take tips.
We will take tips, that's right. And since Seth and I are doing this for the first time together, so I've done this with somebody else, we're going to have our paper with us. So please excuse that if you're shuffling up here. And the other thing I'll apologize ahead of time is I'm getting over a cold, so I may go from audible to either Barry White all over again or going through puberty again in the space of less than 30 seconds. So please try not to laugh too loud. But I'm a pediatrician, so this is kind of part of what we do in February. So today we're going to go through our learning objectives. We have to do that. We're going to do a little twist on the HIMSS steps review. We probably won't be as scripted as you've seen it in some other talks. We'll go over a little bit of what we are, where we're from, and how we're organized. And then we're going to try to define the problem of choosing those IT projects and what makes it so hard for all of us who are trying to manage this big hairy beast called health IT and the big chunk of money that tends to follow it wherever it goes. We're going to go through a governance cycle process. This is one that University of Missouri and Truman independently have landed on essentially at the same time. So again, we don't talk to each other about how we govern. We actually kind of compete against each other sometimes since we're 2 hours down the road from each other. But independently, you can see how two organizations tended to arrive at the same process. We're going to talk about strategy and oversight. We're going to talk about financial planning, prioritization and metrics and the importance of those, execution and accountability, often forgotten, and defining value and tracking that. And at the very end, because culture is so important to our organizations, it really defines who we are. We also want to share a little bit about our culture and why that matters as you look at governing your IT spend. So what are our learning objectives? We want you to take home these 3 things. Assessing the importance and possible outcomes of having really a strong IT governance structure. I think if you've looked at the talks all day today, there were at least 6 or 8 that I came upon. They were about governing your IT, right? Or how important IT is to your strategic vision. I think if you look over the entire conference, you're seeing more and more talks about that, whether we're governing the data or we're governing our IT infrastructure or we're governing how we're making our spend. Also identify those essential steps that it takes to develop a defined IT governance process. And then finally, analyzing the value that lies in early due diligence, both before and post-implementation of any of your IT projects.
So you'll see this slide a couple of times, so I'm not going to dwell too long on it, but obviously in the long run it's about how you drive value, and one way to track that, of course, is tracking on the dollars that you're able to generate from choosing the right projects and having them work out. But I think the other thing is that's a little harder to look at is how do you drive value from what process and methodology, you use to choose those projects. And so that's what we'll talk a lot about today is about that process and that methodology that lets you get to the point where you can have those significant returns and really have a pretty well-oiled machine about how you get projects approved, generated, and working through your systems.
So a little about who we are. So at the University of Missouri Healthcare, we're a 5-hospital system in the center of the state of Missouri. We have our kind of core facility, which has our main hospital. We have our own cancer center, the Ellis Fischel Cancer Center. You're going to hear a lot of firsts on the west of the Mississippi River. So the Ellis Fischel Cancer Center was the first cancer center actually west of the Mississippi River. We have the Frank Mitchell Trauma Center. Now why that's important is it was the first level 1 trauma center west of the Mississippi River, and Frank Mitchell actually defined the standards by which all of your trauma centers are defined, so it's a little piece of history there. We have a freestanding women's and children's hospital about 2 miles from our hospital, and we've just recently doubled the size of our Missouri Orthopedics Institute, and then we have a psychiatric hospital. We have about 67 clinics, so we do about 700,000 outpatient visits to give you an idea of our size. This year we're probably going to break 28,000 to 30,000 discharges from the hospital. We are HIMSS Level 7 inpatient and outpatient. We just went through the revalidation process last year, and we were lucky enough to win the HIMSS Davies Award last year, 1 year behind Truman. I would say 1 year behind Truman. So what's interesting about our location is that we are an academic health center right in the center of a large flagship campus. So I went to school in Mississippi. So those of you from Mississippi, I don't sound like I'm from there, but I can turn it on if I got to. So, you know, when I went to school in Mississippi, the medical center was in Jackson, and the main campus was up in Oxford, and the vet school was out in Starkville somewhere. I said, surely nobody does it like this. Surely this has got to be a Mississippi thing. And then I got to Missouri, and everything's on our campus. The vet school, the nursing school, the School of Allied Health Professions, the main campus, the life sciences center. So surely everybody does it this way. And actually, there's only a handful of institutions that are built that way and have that level of collaboration. We are growing furiously while hospitals around us are downsizing and threatening to close. We are constantly on a bed hold. With Truman, we are the only two safety net hospitals in the state of Missouri, so we do not turn patients away based upon their ability to pay. So we give away about $65 million in uncompensated care a year. So again, very important we pay attention to our budget. And then we are a partner with Cerner Corporation in their first institute called the Tiger Institute, which is a joint public-private partnership between the University of Missouri and Cerner, which has allowed us to move very fast.
So just across this, just to the west of Columbia, we have Kansas City, where Truman's located. Also, as Tom said, so we are an academic medical center. We're also a safety net. You can see at the bottom line, we always highlight the $120 million in uncompensated care. I think if we had only had $62 million, our CFO would probably do backflips. So it creates obviously a pretty hard burden for your organization. You better have good governance about where you're going to spend that capital. Truman is very unique, especially we're two hospitals, but the Hospital Hill location is in downtown Kansas City. And it's one of only about 30 places in the country where you have an adult inpatient hospital, you have our children's hospital, you have the health department, and you have the kind of the local school, the UMKC School of Medicine, Dentistry, Pharmacy, and Nursing, all right there. So it's kind of a health sciences campus. It's a very unique location. We do have a very large, obviously given our mission, a very large poverty population. They have a lot of comorbidities. You can see the 35% of our patients living in poverty. It's a lot more than our county, our state, and obviously the national average. A lot of chronic conditions. We're a level 1 trauma center, also dual HIMSS certified. We're getting ready to do our recertification next month. And we also, like Mizzou, we also have partnered with Cerner in something we call KC1. It's very similar in terms of trying to drive value. But something else that I'll bring up a little bit later when we talk about projects that makes us a little more unique on some of our alignment is that we don't own our doctors, so they're contracted in, all of our medical staff. So it does create some challenges with alignment there. But very busy ED, very busy inpatient. We have a very large behavioral health population that we treat. We actually used to have a behavioral health ED even because of the volume of patients we see in the area. So as we talk about what's the problem we're trying to address, and I always think stories are a good way to start. And so we had some interesting ones, as everyone else. So we're here at HIMSS. We've been walking through that amazing vendor hall. And how many times did you stop and talk to a vendor and they're like, oh, no time to get this. A simple HL7 interface, we'll get this up and running in 2 weeks. Oh, you're on Cerner, you're on Allscripts, no big deal. We interface with them all the time. Yeah, just a bolt-on application, no impact whatsoever. Right? They'll say anything to, of course, get you on the dotted line. So, you hear that on the one hand, and then if you aren't maybe in the IT world where you're used to hearing that, maybe for a radiology manager, and you're like, oh, that sounds awesome. Let's go ahead and buy this and bring it on site, and then of course it never goes as planned. And then speaking of radiology, when we used to have this problem where we thought we had a good process, but there are always these little one-off paths to get around it. So one time, radiology again, through a grant from our charitable foundation, bought a new piece of equipment, which they were told had little to no IT impact. So they bought it, and then of course they needed to get interface to their EMR, and oh, by the way, the room it was supposed to go in was not large enough and the power sources weren't in the right place. So not only did they now have this huge piece of equipment sitting there that we couldn't plug in, couldn't interface, it also didn't fit in the room. So, having governance on how you go about managing those kinds of things to avoid that problem where that big expensive piece of equipment is literally just sitting there is part of why we wanted to have this talk, and why we went down that journey of saying we needed to really put together a very systematic approach to how we're going to manage these projects.
Yeah, and at the University of Missouri, we had a very similar situation that, again, pushed us down this road to having better really oversight and governance of how we were having our spend. So let's just say a chair of a department that deals with skin is hiring somebody, and they just have to have this pathology product. So they come to us, and we said, Respectfully, no, because we already have a pathology product and it'll do everything that you need it to do. And the answer was, no, 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 this individual really has to have this product. And you know it'll interface with Cerner. Okay. So what does a good chairman do? I have deep respect for academic chairs. A good chairman is to take care of their people, right? So if you can't get an answer from me, you're going to go to the person above me. And if that doesn't work, eventually they worked their way up the food chain until they got to the executive vice chancellor for health affairs. Awesome guy who did the right thing for the wrong reason. God forbid we do that. And he said yes. So $250,000 was spent on a software product that can interface with Cerner. We have to ask the question, right? But have you actually ever done that? And the answer was, well, no, but we can. And so we spent $500,000 building an interface to get it working, which, by the way, for something we already owned, but that's okay, this is better, right? For a faculty member who ended up leaving 9 months later because, well, the Midwest just didn't really sit with him very well, So again, that was a huge spend. And then in our Orthopedics Institute, very intrepid group of people had partnered with a local software developer, good friend of mine, it turns out, who built this beautiful iOS-based application to do functional assessments and all that. And 3 years into it, now remember, some of these people had invested their own money in this product. Well, now we want it to interface with the EMR. And we don't want to have to pay for that. So these are the things, I'm sure all of you have had these things happen. And so it's really about, do you know what this is going to cost? What are the steps it's going to take to pull this off? What are the dependencies that are required for this to really be done? And at the end of the day, who's going to be responsible? And should it really be called an IT project? Or is this a clinician-led project? And those are all questions that are important, I think, as you're looking at each individual project that gets proposed. So our staff, by the way, it's good to have people make your slides. I don't know if you guys have people to make your slides. I've never had people make my slides, but when people make your slides, they want to give you Bitmojis. So first they got mine on the wrong because I'm a pediatrician, so I don't wear ties when I go to work. And the first one had this nice tie, and they're like, oh my God, Dr. Silva never wears a tie. Seth has his done, and he was like, that's totally not Seth.
I don't think that looks like me at all.
But we actually have Bitmojis now, just so you know. So what's interesting is, so one of the things that we say a lot at the University of Missouri is there are no IT projects here, right? There are clinician-led projects that we will enable or catalyze with IT, but IT doesn't do a project in and of itself. So when we onboarded a new surgery chairman who had come from another institution, he was a surgical oncologist, what we like to do is we like to meet with them early, kind of say, hey, we're your IT guys, we're here to work with you, and this is how we run things. And he kind of giggled and laughed, and he said, you're joking, right? I've never worked anywhere that does this. I said, well, we kind of have the FedEx mentality around here. If we're going to deliver what you asked for at 10 o'clock tomorrow and you're not willing to be there to sign for it, we're not going to start on it. Because that's going to cost resources, it's going to cost time. We call those orphan projects. They end up with, they're like the island for misfit toys. They just kind of go somewhere where they live forever and nobody ever stops them from happening. So it's really important if you're going to do that, right, that you have good representation. You know what your drivers are when you're looking at how you're proposing projects, who the owners are going to be, and ultimately, you always want to identify who has the go, no-go decision-making capacity for any project as you're moving forward.
Yeah, and we've always looked at it very similarly, that IT is really the foundation for what we do. It's not the driving force. It's helping to enable what we do at the organization. And so we have some guiding principles we always try to keep in place. One of those, of course, is that the patient stays at the center of everything. So if our charge services wants to implement a new piece of software that makes their process easier, but maybe it's going to generate an additional bill that the patient gets, well, that's not very patient-centered. That's not something we really want to be engaged in. And secondly is really have leadership involved from the start, have all the stakeholders there in these projects. And we'll talk about our structure in a few slides, but we didn't want this process where it felt like there were these people in this back room pulling the strings, that they controlled what got approved or what resources got assigned, that there was some small contingent of IT people who really were driving that. And that, I think, is something that is really important when you have governance, that you have transparency, that people know what the process is, how things get approved, that it's not that one person is kind of making that judgment call. And again, it's about having the proper representation. And so even on our governance group, like our VP of HR is there. And granted, she doesn't probably care that much if we get a new CT slicer or whatever. But you got to have all the stakeholders there, all the people who know what's going on, they can permeate back to their staff. And I think that really just helps make sure there's good communication and good oversight.
So I got to ask, anybody here from Missouri? I know we have one Missourian who at least went to school. Yeah, okay. So the show me state, right? So I didn't grow up in America, just so you know. I came here to go to college, so name and accent, I can probably put it on. But I was in Mississippi. I thought the show me state meant y'all were exhibitionists. I had no idea that show me meant we're doubting Thomases. So I fit in really well because I like to say I'm not named after St. Thomas the smart guy. I want you to show me. I've got to feel it, I've got to touch it, I've got to measure it before I'm going to agree to it. And so really, you know, this is our first touch on how culture is important, because in Missouri it really is about, in many ways, you need to show me the value, you need to show me the data, right? If you're going to do that, you have to be willing to assess before, during, and after. Are you really measuring against those objectives for your value, right? And then you have to get leadership to vet those decisions. So earlier today, I was at, I think it was the first session at 8:30 in the morning about making IT part of your enterprise. And what I heard over and over again was that anything you do has to be balanced again. What is the strategic vision of your organization? IT is not the shop that sits in the back anymore. It's like Ginny Rometty said on the keynote when she said, teach your kids math because they're always going to use math. Well, in medicine, which is a very data-intensive affair, as you guys know, there's no way you can practice good medicine without IT to help you manage that data. So IT, just like math, is always going to be there, and you're going to need to use it. So as you're assessing value, you know, what we use is we use a value analysis team, and some of my team is actually here, where we'll look at a project once we agree that we need to do that value analysis and really try to get the all in, right? So it would sound like, hey, that's a great idea. Let me go back to my organization and tell them we need a value analysis team, and we need to do a value analysis on every project that we put out there. So as an example, when we get ready to replace the nurse call system at our aging women's and children's hospital, you know, it's like $1.5 million in expense. You go, wow, that's a big project. We should probably do a value analysis. And I would say, actually, you don't, because it's a piece of hardware, right? We rip out the old stuff, we put in the new stuff, we turn it on, we use it, we kiss, we schmooze, we call it a good day, and we walk away. Because you're not going to really assess the value of that. It was a needed replacement. But if you're going to do a sepsis algorithm to decrease your mortality rate, to avoid a cost or a penalty, or to get money through value-based purchasing, well, now you need to do a value analysis of that. That's a big change. That's software. That's people and processes. So even though it sounds easy to say a value analysis should be done every time, the size of the spend doesn't always necessarily dictate the necessity for that value analysis.
Yeah, and I think, you know, Show Me State really speaks to, for Truman, you know, with our safety net mission, with our large charity care amount that we have to pay out every year, or that we eat, I guess it would be a better way to say it is, you know, our CFO is very big on, you know, you better show me the return on this project. You know, how much are we going to make? How much are we going to save? And so it's very important, obviously, to have those dollars handy. But I think the other piece that our Associate Chief Medical Officer one time in one of our governance meetings said, you know, it's really easy to sit here and come up with numbers that say we're going to save $200,000, we're going to make $200,000. But what about the soft and the soft dollars, right? So if we improve throughput and maybe we don't get more volume, but the patients are happier, and then, you know, maybe our patient satisfaction scores go up down the road. You know, how do you capture some of that? How do you track some of that? I think that's really important. And I think so we try not to always just focus on the dollars, because that can be really easy. But you also want to tackle things that you do for the right reasons. Even if there isn't always that immediate, you do it and you're going to save or make X amount of money. And at the same time, I just think we have a lot of subcommittees that go along with our governance plan that is to make sure we have all the data collected right, to make sure we hold people accountable. We definitely used to have a problem where somebody would come in and, you know, they'd say, probably because a salesman told them, hey, we're going to do this and increase X, you know, by 20%. And then when we'd have them follow up, you know, after the project, they'd say, well, we didn't actually get that, and I don't know, some things went wrong or whatever. And we actually kind of track that now, the people who don't hit their ROI, because, you know, you got to have to realize who you're working with. So make sure you have the right people leading those projects. But I think it's just really important. We always try to make sure that, you know, we've got all the facts up front, that we don't just focus on the dollars. You really have to focus on what's doing the right thing for the patients. So as Tom mentioned earlier, we're going to go through kind of how we manage each of our organizations, these sort of 5 steps. And as you can see, it obviously is a continual, ongoing process. It's not something that's linear. It's definitely something that's more of a flow process that you can continually circle through. And, you know, for us, it's about accountability. It's about making sure you have all the resources lined up. As Tom mentioned, you know, we're very resource constrained. If you only have 8 people who write reports, well, you can't just have a free-for-all on how people request data, and you know, you have to have some sort of semblance of how those get worked and how they get prioritized. So we're going to go through each one of these steps and can talk about how we handle them within our respective organizations. So first one, of course, is strategy and oversight. And at Truman, we're very big on that everything we do has to go back to our strategy. So whatever project, whatever piece of software, whatever workflow, whatever you're trying to do, if you need capital, you need resources to do it, then you have to be able to show that it aligns with one of our strategic pillars. This can't just be something you want to do because, oh, it's so cool and I saw that another hospital did it. So how do things line up with our strategic objectives?
Yeah, so this is a quote from Steve Ekman. I wish I could take credit for it. Steve Ekman's one of the vice presidents at Cerner, and he actually come to visit us about something totally unrelated. He goes, you know, I keep getting asked about this governance thing that you guys are doing. And I said, well, you know, it's always a work in progress. And this is what he said, you know, in order to move forward, you've got to have a strong governance structure, but you also have to have the will and discipline to actually stick to it, because the alternative is chaos, right? So, you know, you got to remember that a governance structure has to be dynamic. You know, we get about 26 reference visits a year in person to the University of Missouri, and I think in the last 2 years, every one of those by usually the first part of the second day is, wow, could we just get a copy of your governance structure? I said, you know, governance is like, to quote our CIO, it's like a fingerprint. All of our fingerprints are remarkably similar, but yet incredibly unique. And so within your own organization, how you govern is really going to be determined by, you know, what is your strategy, what's the vision, what's the culture of your organization, the size. But what we want you to take away from this is really the principles of that governance. You know, in our institution, we say that governance is always clinician-led and IT-enabled. So what that means is that at every level, all the way from the C-suite down to our operational governance, and we'll talk to you about this in a minute, there's always somebody from IT that knows that area that's going to help a clinician make an informed decision. IT is never making the decision for the clinicians or for leadership. Really, they work side by side. One is not necessarily telling the other one what to do, but they're enabling each other to move forward. So it's kind of like, you know, in the absence of that, what's the chaos? So in Cerner, we call it application management services for you guys out in the Epic world, the McKesson world, the Meditech. I'm sure you have something very similar, because in the absence of this, what happens is some well-meaning clinician gets the direct line to application management services and says, hey, buddy, can you make this change for me? How many times has that happened to you guys? Right. Can you make this change for me? And the engineer over in wherever they are says, oh, I'd be happy to do that for you. And they plant this giant crater in the middle of somebody else's workflow that then you get a call, usually a very impassioned call about what the heck just happened to my workflow, and then you've got to try to figure it out. So it's really important to have that governance there. I'm a big fan of doing ultramarathon kayaking. I've done some tandem kayaking. That's a great way to either love somebody or hate somebody after 4 hours. And what I've learned is that if you're not paddling together, you might as well just be paddling your own boat. It's just a really big and heavy boat now. So I think governance is all about how do we get ourselves working together.
I think that's actually perfect timing, because last night I didn't get to go out and enjoy the parties, because as I was leaving, we got a call because somebody back at our hospital had asked for that, they got that bat line and asked for a change and had broken something way downstream that they wouldn't have thought of. So that kind of thing is very important. And for us, you know, at Truman, it's really about creating that really all-inclusive process. You know, I mentioned before we had that way where people could maybe get around it going through charitable. Or we used to, for our governance program, we try to put in like hard numbers. So like, I think if it was over 200 hours of IT resource time, or I don't know, $40,000, $50,000, you had to go to this committee. Well, so what did people do? They worked with their vendors and got it down under $40,000, or they figured out a way to get it done in less than 200 hours. So, you know, people would find little ways to get around it and still cause issues. So we wanted to make sure it was all inclusive, and made sure people knew what those processes were. And if nothing else, we want it to be, I'll keep coming back to transparent. I mean, after we call our group ETAC, and I'll show it in a moment here, but we post all the minutes and all that stuff out there for everyone to see. Our project approval list is open for the whole organization to look at to see where things get scored. You know, it's very important people know what's going on. We keep going back to that. We don't want people thinking there's some small group of people in a back room who are approving or denying projects, and if you aren't buddy-buddy with them, then you're not going to get yours approved. So that's, I think, really one of our big pieces we're trying to work through.
And that's a perfect segue into, so a lot of those principles are what we follow at the University of Missouri. So again, this is just our structure. Again, it's one. Yours will be different. But just to give you a couple of high spots here, at the very top, because of that, you know, $750,000 spend for something we're actually turning off this year, we have what we call the Tiger Institute Prioritization Steering Committee, right? And in that room is the entire C-suite, nursing leadership, physician leadership, IT leadership, so that when we're talking about which projects we're going to approve or not approve, there is good visibility and there are no secrets. There's open discussion, open disagreement, but when we're done, we're agreed and we move forward. The next level is really our operational level, and that's where we kind of try to break out the way we manage this thing we call, you know, our health IT into more functional groups. And each one of those groups is led by a clinician, either a nurse or a physician, with an IT architect standing right next to him. So very quickly you can answer the question, should we? If we do, what will happen? If we don't, what will happen? And then how do we respond to this request? So when I took this job, my imperative to the chairs of every one of those committees is that if the answer is no, it comes from you personally. And it's always no because. And you know, when you say no because, you don't get a lot of pushback because the requester obviously has no idea how big this thing is we call our health IT implementation. So we owe it to them to give them an explanation. And much like Truman, we're very transparent. We actually built our own kind of homegrown interactive request management system so that users now, when they make a request, are told every step of the way, this is where your request is, and that system actually builds the agenda for every one of these operational governance groups. So to call out a couple that we just got our HIMSS revalidation, so the HIMSS examiner called them out. It's like, wow, so you got this thing called the Portal Steering Committee. What's up? Who's in that? I said, well, the entire C-suite's in there. He goes, really? For your portal? But you know, our leadership is very big about patient engagement, and with our partnership with Cerner, we really want to push them hard on how can we make the patient portal something that someone who's young, I said young, I did say it, right, who's young and healthy is going to actually use that thing, because otherwise, if you don't have a chronic problem, why are you going to go to your portal? We want it to make it the place you come to take care of your health. And then the EMR Council is one that always gets a little notice. People say, what's that? And I affectionately call it Dumbledore's Army. No reference to you guys going to Harry Potter tonight. But, you know, I think if you're going to be effective in how you implement health IT, especially with the EMR and the fact that it's got its fingers in everybody's life and every moment of their life, you have to have people who use that, who can be proselytizers of it, but who will also give good feedback about what's not working in their area in a way that's context sensitive. The help desk cannot understand the problem of a surgeon in their clinic, but a fellow surgeon in that clinic can hear that problem and now translate that into something that we can fix centrally. So we pay 10% of their salaries, their cross-functional representation, and most importantly, the reason they're Dumbledore's Army is because the CIO and myself choose those people individually. We don't ask the chair first, because again, all due deference to academic chairs, they got to keep their budget whole. So if I offer to pay 10% of somebody's salary, you know who I'm going to get. The most expensive person in the department who's not making their salary, and that's not who I need. I need someone who's going to listen, who's going to openly disagree, and is going to help us move forward, and then translate that out to their peers where they have a sphere of influence.
Yeah, and ours is fairly similar, but what I think makes us a little unique, you see ETech, that's our Technology Advisory Council that sits in the middle. You can see there's another layer of governance that we put in place above it, and then you actually see our board of directors and actually Cerner, who's our EMR vendor, and they're like 2 miles down the road from us. And you see that layer of governance that's in the middle, and that's a little unique to us, and why we have that sort of second level where leadership from both organizations sit. Our president and CEO, Charlie Shields, Zane Burke from Cerner sit on that, is that part of it's about accountability, right? We hold them accountable to make sure that the technology being provided is going to work, is going to do what it's supposed to do, and then they hold us accountable that we'll put the resources in to implement it, to train on it, to use it appropriately. So we have all these different layers of governance in it. ETAC is our main group where all those projects come and get approved that we'll talk about in a moment. And then you can see that off to the side we have our MedExec, nursing steering, all of our medical staff committees. Underneath we have some groups like population health and our operations for how we operationalize all of our projects. But this approach has really, really helped us over the last couple of years. And like I said, ETech is basically all of our vice presidents are on that. It's chaired by one of our chief operating officers. All of our projects go there. It's where we do all of our reviews and such. And all those pieces fill into it. So when we talk about our strategy, when we talk about how our physicians play into it, one of the best things that came out was we do a physician engagement survey and an employee engagement survey every year. And we scored very high from our medical staff on that, these solutions help make patient care safer. And so, we know that there's value, that we want to make sure they have their say. We actually have a standing agenda item on our MedExec, their agenda every month to talk about the EMR and solutions and how we can support that. So it's bi-directional with support. And what I think we found early on when we first went with an EMR and all that was, I don't know if it's the way we did it or maybe it's just doctors in general, they weren't that thrilled about the process. But I think over time, and they've seen the results and what it can do, now we just hear a lot of they want to be involved. And I think before people were scared to schedule a provider out of their clinic and take that time away. And you do have to be cognizant of that, but if there's value in that and they want to be engaged and frankly, if you want to be successful, you need them engaged, then I think we're starting to see that has definitely been a shift in the way people think.
Yeah, couldn't agree more.
So the next step, of course, is the big one, the dollars. That's what everyone cares about is, like I said, what our CFO would say is, you can show me the greatest slides, the coolest product, what's it going to mean financially for us in the organization?
Our CFO always just says no. That's what he just says no. So at MU, our budget approach is very centralized because our governance is centralized. Now, the cool thing there is you can't hide anything when you centralize everything, right? There's no gotchas. You know what the all-in cost is going to be. You know what your planning costs are going to be. Your maintenance costs are going to be. So, but if you're going to do that, you have to have good representation. And I told you about the TIPS committee, that we really have representation from all aspects of the leadership in the organization. It's not really about IT deciding how the money's going to be spent. It's not about your CFO making that decision. It's the, I call it the EIEIO of the C-suite. You name the C whatever, and they're all in that room. The head of our physician practice group is in that room. So we're making those decisions in a very collegial and collaborative way. Now, I will say that our CFO is very forward-thinking in the sense that he doesn't nickel and dime IT. What he'll say is, what is your best guess for what you think you're going to need for next year? Okay, here's your bucket of $10 million. Now, we know you're not going to spend that all on January 1st, so we're going to govern that spend throughout the year. Now, here's the cool part. If we only spent $6 million, guess what? The next year, he's not going to say, well, you only spent $6 million. Let's start at $6 million. He's going to say, what do you think you need for the next year? And if you didn't spend something in this fiscal year because that project carried over, you could go and just carry that spend over, and it's not going to impact against the budget that you expect for the upcoming year. I realize that not all chief financial officers think that way. A lot of them tend to close out the year. Let's start the new year fresh with what did you spend last year. So it's kind of if you don't use it, by God, we're going to spend it at the end of June. So stuff just sits on the loading dock and never gets used because we had to blow our budget by the end of the year. His thinking is very different, and that really plays into our ability to have this centralized budgeting process.
That actually is a great segue. I was talking to someone downstairs that a couple years ago, when Truman was getting ready to purchase computer-assisted coding, we identified a funding source and got the money, and then when we actually took it to ETAC, I told her that I was watching our associate CFO, and he was giving these weird looks once we talked about the funding source, but he didn't say anything, and they approved it. And then afterwards, he got with myself and our CIO, her name was Mitzi, and said, I didn't want to bring it up in the meeting. I don't want to alarm anyone, but we kind of had taken that money and already used it to upgrade our time clock system. So he's like, we'll find out, we'll get the dollars because it was somewhere else. We said we budgeted, it goes, but technically your funding source no longer exists. So, but we're the same way. Our CFO, they understand the value, and we understand that IT, like I said, is a strategic asset to the organization. So nickel and diming your IT department is only going to hurt you in the long run.
That's right.
And we're pretty lucky that our CIO, Mitzi Cardenas, chairs our capital assets committee. So obviously, he's a very strong voice in what we purchase and helps kind of bring together our C-suite in doing that. But what makes it a little different is while most IT projects and costs do go through IT, it's their operational budget for our EMR and our billing system and all that, we do let departments kind of drive some of the more specialty software. So like HIMSS, their operational budget does actually cover the costs of our computer-assisted coding. And there's a couple areas that are like that. And I think that we like that model in some sense because it helps them make those departments feel like they own it, like they're responsible. It's not IT trying to drive the bus and control all the strings. They're the ones going out and selecting the vendors, and they're the ones who are supporting it. So there is some kind of both ways we track that. But I would just say for Truman, from our capital process is very, very stringent. If we've got that $120 million gap that we start every budgeting year with, that you have to sort of make up in operations, we get a lot of asks from the organization. We have to do a lot of prioritization, a lot of nice to haves, need to haves, when do you have to have it kind of thing. But it definitely helps us that our CIO obviously is the chair of that group. And then for us, kind of leading this next section, for Truman, this is the most important thing that we went through when we redesigned our process, which is how do we go about prioritizing what projects we do when, and how do we track that those ones are successful?
So at MU, I'm happy to say Robin Jones is here. Robin Jones is the director of our project management office and keeps us on task. So we have our pre-reads, we come in, and the first thing we're going to do is look at our proposals. And we learned very quickly that there were too many proposals to try to get done, and we got the entire C-suite sitting in this room for an hour and a half. Good luck trying to get them all there and have a quorum. So what we did is we pared down that group into a subcommittee. And what we do there is, one, we go through our list of projects and say what needs to be kind of slotted up and down, what changed in priority. And we also do what I like to call the Shark Tank pitch, right? So you've got an idea, You want to pitch this project. We get some IT staff to come with you, help you fill out what we call the short form. And really what we do in that smaller group is ask the most important question: does this align with the strategic initiatives of this organization? If the answer is no, then we're going to go back to the individual and say, this really doesn't align with what we need to do. It's a big spend. Or we may ask other questions like, do we already own this software? Or my favorite one is, are you telling me you just didn't learn how to use the software you already own? How about we go back and make sure that we're actually optimizing the use of what we've already paid for? So we try to get that out of that larger group. In the larger group, we have what we call the long form. This is the big pitch. And we've learned that when you have somebody come make the big pitch for a lot of money, they need to show up. So don't send their minion in to come in and do the presentation, because we are pretty aggressive in that room. They need to come in and be able to answer those questions. So that's lesson number 1. Lesson number 2, they get 10 minutes. They don't get half an hour. They need to be ready to present. And lesson number 3 is when they're done, they need to leave. Because what we've learned is when they stay, they get very impassioned and kind of emotional about this project they're kind of married to. And now you want to just approve it because you like them. And the answer is you can't approve stuff that's expensive because you like somebody. So we've learned to just politely say, thank you. You've answered all our questions, and now you can leave the room. Once we've addressed those issues, our process is to go through ongoing project assessment. Are we on target, off target, meeting our goals, not meeting our goals? And then we can correct for drift. So an example with us is we went live with Nuance. We spent $2.5 million. The University of Missouri, anything over $1 million has got to go to the Board of Curators, and they only meet like every 2 to 3 months, so there's a delay right there. So you want to try to stay on task, and we were not meeting the mark. So as an executive group, we said, have we done our due diligence in educating and building adoption? Yes, great. Turn off the transcription system for everybody but the trauma surgeons, because we've done, and it was amazing, within a month, everybody was using Dragon, and they were happy to use it. They just didn't have to, so they didn't make that switch. So again, that's part of what we do. And then lastly, we hold individuals to task. If a project is in the red, we're going to ask that executive director to come back to that room. Can you please explain why this project is in the red? And you can't just kind of go one off and say, well, I made a unilateral decision that what we bought I didn't like. I turned it off. We went back with what we had before, so I'm just going to renew that contract. You really can't do that. That's got to come through this group so that we're paying attention. That's the spend that just kind of, it's like the gift that just keeps giving if you don't pay attention to it.
And we do something very similar. Part of our process is we do that early approval or review, and we didn't used to. And what we found was Seth comes up with a really cool idea. And he goes out and he does kind of an RFP, and he gets all the information. We talk to IT, and we figure out how many hours and what resources and all that. And then we'd go to our governance meeting, and I'd say, this is what we'd like to do. Here's the call, all this information. And if it didn't fit with our strategic plan, if it wasn't something leadership wanted to do, you may have just said, well, then we just wasted 4 months of negotiating and all this time and effort. So we've kind of mirrored what Mizzou does. So we have a kind of a short form. You fill out a business case template. It goes to your executive, not your boss. If
Right.
my frontline manager puts it in, it goes to our CIO. She has to approve it. We do that for 2 reasons. One is validates that it's part of our strategic plan. 2, what we were finding too was, we were going to these governance meetings, and social services is saying we want to do X, and they're looking at their executive, and she's like, I had no idea they were bringing this. So, it helps make sure everyone's on the same page. They know what their staff are working on. But we do the same thing. You come just with that very high level. What is it? We do some basic groundwork about, what do we guess it's going to cost in terms of dollars or interface time or whatever it is. And then we go through the process of, okay, if it's approved, same thing. We have a kind of a weighted voting that we do, that all the leadership team does. And then we actually sit there and we prioritize. We look at all the projects on our project approval list, because, these ones that got approved last month, where's this new one going in? Above, below? How do you slot all those different things? And we do that as a group. And then the big thing, like I mentioned before, and kind of what Tom said, is we do make people come back and prove what they said. So if you came in and you sold us on a project that said it was going to generate X amount of dollars in whatever time frame, then when you come back after that time frame, you better have generated those dollars, or you better have a good reason why you didn't. And that's why I said we keep our PMO, our project manager office, does keep these unofficial tallies of people who don't meet their ROI. And it doesn't stop us from doing projects, but it just means maybe we need to make sure they did their due diligence correctly on their future ones. But it's really important that we get all those updates. And one thing I'll piggyback off Tom said was, we were finding that too, where people, I don't know if they were scared of ETAC because it's leadership or what, but they would send, a lower level manager or something in their place because they were scared to come present. But they need to be there. This is their project. They're the ones who know about it. And yes, the questions can get tough, especially, I'll say, from our finance team. They usually want to really get in those dollars. But if you aren't prepared enough to come and sell it to them, then I would say you probably haven't done your homework enough to be ready to do it anyway.
That's right. And there's a halo effect here. So, you know, at the University of Missouri in the last 2 years, IT has given over $6 million back to the finance department from capital spend that we did not spend. Now remember, you got to have a forward-thinking CFO who says if you give it back, doesn't mean you don't get it next year, right? So that's important. But what we have found too is if you, and again, your governance process has to be your own, but if you're good about sticking to it and you have the rigor around it, your staff will understand that. And so what happens is our staff start thinking more clearly about their projects. They're kind of vetting themselves within their own departments with their executives before they even get proposed. So our rejection rate continues to go down because the projects they're cleaner as they come through. It doesn't mean they're not innovative. It doesn't mean that they're cool or sending us off in a neat direction, but they've thought the process through. So it allows that wheel to just turn faster and faster. And again, it's wonderful to be able to go to your CFO at the end of the year and go, hey, thanks for trusting me with $10 million. I'm going to give you $3 million back because we didn't need it this year because we're following a process.
I want to ask you guys to raise hands and say how many of you would do the same, but I don't think we would. We'd be like, oh man, we got to hide that. But I think that's really awesome that you can do that and you can show value, and obviously that there's trust both ways. I think that shows obviously that if you've shown value over time, then they understand, you know, why you need some of that information. And then of course the next step would be the execution, how you follow through with it, making sure stuff comes in on time, on budget, with the appropriate resources and all of that. And for us, we really look at that as kind of a 4-step process. So I already kind of mentioned what we do with that initial request. You know, if it gets approved, then that's when you start really diving into it. You know, if it's an RFP, whatever it is, vendor selection, get all your hard numbers, make sure you've got it nailed down. Then you come back to ETAC and you say, okay, you guys formally approved this idea. Here's what we know. We want to go with this vendor. It's going to cost this. It's going to take this amount of resource time. And we start talking about, okay, how do we slot this in and where? And that's really where resources come into play. And that's a really big reason why we like our model, is we are so limited on resources for interfaces or reports or the people who manage, you know, the clinical systems versus the business applications. You know, they can only do one project at a time or be in one place at one time. So approving everything doesn't really help if you only have one resource who manages that. Like we used to only have one person who could do our behavioral health EMR. So assigning that person to do 14 projects probably doesn't really help. Probably didn't help our sleep. So once that gets approved and we have it slotted, you move on to design and implement. And this could take a long time, right? So we're going through a conversion of our billing systems, and when I usually tell people that, they start saying a little prayer because they say that's usually like a kiss of death when someone switches rev cycle systems. But so they'll come and do monthly updates to this group. You know, how are we doing? Are we on track? Are we in the red? Or, you know, how all that goes. And we'll continue to watch implementation, and not just to check up on them, but again, you know, are we on track so that we assume that interface resource is going to be available starting March 1st? Right. Is that still true, so we can then move them on to that next project? And then most important, again, is that last step, which is really where we used to fall off, which was you came and sold us on it, we implemented it, and then we just never circled back. So, you know, come back and show it did what it expected, or are there future considerations we're trying to do with it? And again, kind of keep that whole cycle going.
And that's the key, right, is that what we're talking about is a cycle. And this is not new to you, right? So as a physician, what do? We assess, we intervene, we reassess. That is the mantra. I'm not an ICU doc, but that's the mantra of every ICU doctor, right? If you're going to do something, come back and make sure what you did made a difference. And then you just churn that cycle. But whether you're doing quality improvement with PDSA, or you're more of a, you know, Six Sigma and you're doing DMAIC, whatever you want to call it, if you're in that kind of culture, you know the wheel constantly has to turn. So these are some of the benefits that we'd like to show you for our organizations. You know, we're both HIMSS Davies Award winners. Again, selfishly, they won first, we won second. But that's okay, we applied again. By the way, you should know you can win that more than once, I'm just saying, so if you want to go out there. But you know, HIMSS Davies is really about, did you get the value from your IT implementation, right? So I'll tell you that it's really hard to tell your story looking backwards. It's far easier to tell your story when you have a rigor around assessing value before, during, after, because now you can tell your story much more easily. And just a couple of call outs here. You know, we reduced our catheter-associated UTI rate by 25%. Now, did we do that because we turned on some advisor and Cerner? No. We already had a culture where the nursing staff wanted to improve that. We put that on paper. We got it blessed by executive committee. There was a relationship between nurses and doctors. And then they said, wouldn't it be cool if we could automate this in the EHR? And that trust was there that if a patient didn't need a catheter, you didn't put one in. And if they didn't need it any longer, you didn't have to call a doctor, you just took it out. So now patients are avoiding catheters altogether, and that infection rate is falling. our sepsis-associated mortality is falling because of our sepsis algorithm. We actually built our own interface to allow patients to access physician schedules online. I know we can all collectively gasp when we tell a doctor we're going to open your schedule to your patients. And oh, by the way, you don't get to have all those fancy rules that you used to have. What's pretty amazing is when patients use a Travelocity experience to choose their appointment, here's a big shocker. They actually show up. So we've reduced our did not keep appointment rate by over half. Well, why is that important? Well, in primary care where I live, if you schedule an appointment online, my missed appointment rate for that appointment is less than 1%, which means I don't have my staff sending out letters. They're not jockeying for appointments on the phone. We've drastically reduced the hours that our front desk are spending doing something that is not value added when the patient could just make their own appointment. And then lastly, we invested a tremendous amount of effort and income in changing the way that our nurses interface our devices to the EMR and associate them with the patient, reducing a drastic number of steps and saving about 36,000 hours of nursing time a year in just scanning barcodes, right, and writing stuff down. And so what does that mean? Did we fire a bunch of nurses? No, actually, by the way, if you're a nurse and you want to come work in mid-Missouri, we're hiring like 600 over the next 3 years because we're busting at the seams. So come on down. It's a fun place to live. What our nurses will tell you unscripted is that they provide more informed care of their patient because they're not spending all this time writing down stuff that they're going to go put in the EMR later. That part's taken care of. Now they're much more informed when they're at the bedside. And we were able to, yeah, I forgot this big bubble showed up. So we got a return on our investment for HIMSS Davies, which we won last year, of over $60 million.
And again, we like that people help put us our slides together because then they have these nice bubbles. But no, we have a very similar path. And a lot of the projects we're most proud of, it's not always that straight dollars, the same thing as Tom said. So I mean, when we won our Davies Award, one of the big case studies we did was about interpreter services where Truman, given our patient population, we're an urban core, we have a very high percentage of our population which does not speak English. And so we have a policy which was, for security, you can't page PHI. So if there was someone in the ED who didn't speak English, they spoke Somali, Spanish, whatever, they'd have to page overhead, interpreter service, Somali speaker to the ER. And they would show up in our ER, which is a very big ER, and would just say, interpreter here, and whoever got them first won, even if that was not the person who they were ordered on.
That's right.
And it just took forever, and you couldn't get real reports on how they were doing and all that. So we worked, and we built them a dashboard. We built you kind of place it as an order now, so that that person then they know exactly what room, the patient, the bed, all of that. They can go, they can track their progress. We're able to increase their number of contacts, all that sort of information. And it's really cool. I mean, again, that's how you leveraged our IT systems to really build a foundation that helped us treat our patients better, help them get through the system faster. Another one that we're really proud of, and this is very recent, is kind of in the middle of the blue bubble. It says 80% improvement in referrals. Truman's a pretty big hub in Kansas City for receiving referrals. A lot of hospitals who don't want to treat somebody who can't pay will just shoot them over to us because they know we have to. So we get a lot of referrals from a lot of different places. And they're coming in by fax and by paper, and there's 27 fax numbers, and the one on the website doesn't match the one that we hand out on our cards, and it was very hard to manage. And so we implemented an online referral system. We got a lot of our partners to get up on it so we can track referrals. They submit them electronically, we send the records back, there's status updates just like on your phone. Oh, this patient's now scheduled, this patient's been seen, we've sent the records back. And we actually reduced the amount of time it took for that referral from the time they submitted it to the time we got them out the door by seen and that record back by 80%. And that makes our clinic staff really, really happy because they're not dealing with phone calls all the time. They're not trying to find that one piece of paper because Sarah is the one who manages referrals in the endocrine clinic, and when she's out sick, no one knows what's going on with them. There's a lot of transparency. There's a lot of help there. And so when we talk about the things that make people happy in our 0 minutes of downtime, when we have our upgrades, we don't have those lag times. We do what we say we're going to do. Really help drive value and help people have faith that we have the right process to implement these things. And the other point I'll just make is a lot of the things up here, like referrals, like interpreters, those aren't really IT projects, right? I mean, again, those are led by clinical staff. Those are led to be patient engagement, right. Which is why we're doing this, why we're working for hospitals and not working for vendors. So, it's really been phenomenal. And in some ways, we kind of laugh that, healthcare seems to always be the last one to get technology. For example, we just started doing at Truman the patient signatures electronically, and I know there's still a lot of hospitals that don't do that, and it's weird that You know, you check out at literally any place. I mean, you bought coffee downstairs and you check out on an iPad, but every time you show up to your doctor's office, you're signing on paper. 4,000 forms.
Exactly.
It just drives me batty. So, you know, how you can do those things. And the interesting thing about a project like that we've done and we've been tracking, we went live in August, is, yeah, there's some cost savings. We don't have to buy these forms and things like that. But it's a huge patient satisfier, because it used to be for us, if you came to Truman and you saw 3 clinics in that day, you were signing that same form 3 times, every time.
Yep.
And now you sign it once, the system knows, oh, you don't need to sign it again for 6 months. So you check in that next clinic, you just sit down, you wait, you get called back, and you can start that visit faster. So again, it's always about how we keep the patient at the center. And again, we've had a very nice return. But I will say this is something Mitzi usually says. We do a lot of reference visits too, and people will ask, so did you get all the benefits out of your e-mark version? Did you make your return on investment? And I'll never forget what she said one time. She said, you know, technically, yes. Technically, we did. She goes, but you never really sustain it, right? Because there's upgrades and there's new systems you purchase. You know, there's add-ons, all of that. So she says, it was less about direct that, hey, if it cost us X, we made back X, or we saved that. It's all the stuff that goes around it, that because we took the time and the resources to do this right, that we're going to get all these side benefits that really help us out. So. And then, of course, the last one we talked about, which is what we just sort of spoke to, was the value, which comes back to that first slide of you know, how do you really use these governance structures to really drive that bottom line, to really make sure that you're working on the things you should be, that you have your resources lined up, that people know what you're doing, that if you want to bring a project forward, what's the process that you have to do to get there. And I think some of the bubbles speak to themselves. I don't know if there's anything else you wanted to highlight on one of those.
No, I think, you know, when you look at, you know, provider satisfaction, I mean, I'll speak for the doctors in the room. You know, if you want to derail a meeting, pull the pin on the EMR grenade, throw it in the middle of the room, and if your meeting's got 20 minutes and you don't want to discuss that hard to discuss topic, do that, and your meeting will be over in 20 minutes, because they'll just rail on it, right? So what we're seeing is, because we have this rigor around the way we deploy, we measure, because we can communicate back, we're seeing our EMR satisfaction rise every year. I will tell you that no matter what survey you do, there's one question you're going to ask that's always going to get you a negative response. It's never going to be fast enough, right? As soon as you make it faster, you just raise their expectations.
Yeah, that's a good point.
So, you know, we talked about at the very beginning, at the end of the day, it comes down to the culture of your organization. So we wanted to take 2 seconds to just kind of share the culture of each of our individual organizations, and I think you're going to hear some similarities there. And again, we didn't consult each other to say, hey, what are you guys doing at Truman? So at the University of Missouri, we talk about the culture of yes. This sounds like an elevator speech, but stick with me, right? What does that mean? It means together, we as a team will care, deliver, innovate, and serve. So those don't mean anything unless you put behaviors with them. You need to recruit behaviors to your culture that allows you to be somebody different. Right now, you're all tired. You're paying attention, right? Yeah, you are, right? Okay, so like an hour from now, you're going to be out in Harry Potter Town being completely crazy, being a kid all over again, because it's accepted to do that. It's a behavior you recruit when you're going to a theme park. But here, you're an IT professional. You're supposed to pay attention and not smile. So what does that mean when I care? It means this self-acclaimed introvert, trust me, I am. This is hard. This is learned, right? Will actually greet you with my eyes. I would rather have pointed to the floor when I'm 10 feet away from you, and I'll actually greet you 5 feet away. Why is that important? Because I do that, now I'm going to anticipate your needs and say, yes, I can do that, and I can do this for you, right? I'm going to greet you, and I'm going to say goodbye in a warm way. How does that relate to organizational governance? Because that yes and is really important. That's a great project. And have you thought about how this could be deployed a different way? And would you like to participate in other parts of our governance? That's important. When we deliver, and Seth just said this, right? We say do, 1-to-1, right? If we say it, we're going to do it. We agree, we execute. We don't execute 15 months later when now it's not important and we spend all the money, right? And it's a big impact in a small wake. We get in, we get done. We don't leave a lot of mess behind. We don't leave this trail of almost dones behind a project. You get in, you execute, and you leave. And somebody asked me one time, doesn't this structure quash innovation? Well, innovation finds a way in our organization. So maybe you can't do this project you want to do now on a grand scale, but that's a cool idea. Let's go do it on a small scale and see if it works. And then we can see if it's got the ability to spread, right? And it's everything you need and nothing more. So I think there's a tendency when we're governing to say, wow, that's really cool. And then there's all these add-ons that want to get plugged in. We're like, what is it that you really need? Let's deal with that. These other extras sound great, but how about we prove this works first? Let's be good stewards of the talents that we've been given by our organization. And finally, serving is easy, right? Serving means that I don't vent publicly, and that is there anything else you need? Because I have the time. So why is public venting important in governance? Well, we heard this afternoon about the meeting that happens after the meeting. You spend the whole meeting talking about the things you don't need to talk about, but you don't talk about the thing you should have talked about, and then you have the meeting after the meeting, and decisions get made, and money gets spent, and you have no idea where it came from. So in our governance, the way that relates to our governance is in that room, we will disagree openly, but in a collegial and professional way. But when we leave, we have agreed, and we don't walk out and go, that's never going to work. Let's go talk about how we're really going to spend this money. Or, hey, by the way, good on you. We actually already spent your budget. We just didn't tell you. So that's where culture is so important. And I'm a firm believer that you're not limited by your culture. If your culture is limiting you, that you can change your culture. But it takes a concerted effort to do that.
Yeah, we're very similar. The We Are All the patient experience was really an effort. It kind of started out of the value-based care stuff and HCAPS, but it's that's great if we do if we give you great care where you're back to doctors and nurses, but registration was awful, or you went to go get your medical records and the portal wasn't working and you went to go and they didn't get a good experience. That doesn't help. Everyone plays a role in that. Our CEO has really gone about the sort of the hospital, the hotel route, meet and greet in 5 feet, things like that. That everything we do is supposed to make them feel better. We never want to be in that situation that we say, well, that patient has to come here. That's just the way it is. And we have our processes, and it's true, some of those patients don't have a choice. If you don't have a payer source and you can't really afford to go to another hospital, you're going to come to Truman. But you deserve to be treated with the same amount of respect as somebody who has the best commercial insurance in the world and is going to whatever private hospital. So it really is about taking care of it and acknowledging that everyone has a role to play in that. And so whether you're in environmental services or you're the provider, everyone impacts that patient's stay. We're very big on rounding. Though I am pretty much an extrovert, I'll talk anyone's ear off. Maybe it's because I'm not a caregiver. I really get awkward going into patients' rooms. They're laying in a bed, they're hooked up to 50 different machines, and start talking to them. But we're encouraged to go do rounding.
Well, that's because they can't talk back to you when they're hooked up to 50 different machines.
That's true. I never know what to say, but I've actually enjoyed doing it. You start having this dialogue, and people realize, they're there to get better. We want to do right by them. We want to make sure we're treating them with respect. And really, the whole organization has a role to play. And you're right. It's a culture shift to treat these people as people, not as kind of a number or as, oh, there's another GI bleed or whatever, and just go through with it.
So at this point, we're supposed to remind you to fill out your evaluations, just so you know, if you like this and you say we're great, they'll ask us to do it again, and there's wine waiting outside the door. So we have a few minutes for questions. If you guys have any, we're happy to entertain them. If you're like me, trust me, I truly am an introvert and don't want to ask a question, you can get our email addresses. And we're firm believers that this is a journey, and all the best journeys are the ones that we share and not the ones that we take alone. So, yes.
Hi, my name is Jimmy Small. I transitioned from more of a health IT role to, at least in my organization, to more of an informatics, trying to bridge the gap between operations and IT, who don't always communicate the best way. One of the challenges I have at times is because I'm very closely connected with operations, I really understand some of the pain points in their efficiency and how they collect data in the systems, or how their workflow could be improved by some modifications. But where I really struggle with is being able to translate those soft savings or baking that into an ROI to make an appropriate pitch for, I think you mentioned in your governance process, the short of the long pitch. Do you have any suggestions or recommendations on how a non-IT finance person can appropriately value and then ultimately come up with an appropriate or influence an appropriate ROI on an investment, so a reasonable determination can be made?
Yeah, that's a tough one. So one, there's nothing that beats going to spend a day with a physician in their clinic.
Mm-hmm.
Even though you know what they're doing, that it's kind of like when people come to me and say, I'm going to go practice pediatrics, what book should I have? I'm like, I don't know, come spend a day in clinic with me, and they'll leave with like 12 books that I recommend, but I got to do it kind of in my flow. I think it'll also give you a sense of, you're right, it's very hard to quantify that. So you have to look at lost productivity, physician burnout. So we're going through this with our family medicine department. They were burning out in a huge way. So what we did is we looked at, our product is Cerner, we looked at lights on data, right? It's not financial, but what's the time they're spending? How much time are they spending at night, right? This is killing them. How much time are they spending that they could have been seeing a patient, there's revenue right there, right? So all of that sometimes isn't a hard benefit. It's a little bit softer. But the financial people, you know, if they're forward thinking, they're kind of getting it that, you know, the most expensive piece of equipment you have in any hospital facility is not your Da Vinci robot, by the way. It's the doctor or the nurse practitioner. It's the licensed practitioner who can do something that drops a bill. And if they're doing anything that does not drop a bill, then you're wasting that effort. It would be the same as running your helicopter out front just to say, doesn't that look cool? And you're burning fuel. Your CFO would be having puppies over that, right? But if you say, well, I got doctors standing in the hallway documenting for 15 minutes for a 10-minute appointment, they're like, I don't know, show me the money. It's like, well, they could have been seeing another patient if you made this more efficient. So sometimes you got to be a little creative in that regard. But I agree, it's hard.
I was just going to say the same thing. I'd say, we tell people all the time, go spend time in a clinic, go talk. Don't just say in a 1-hour meeting, explain to me your workflow. Like, go watch how it actually works and provide.
You got to feel the pain. Yeah.
So what about in the scenario where you're, like, because I work for a payer, so we're not generating billable events. We're generating on the back end, you know, cost savings or enrollment retention and things like that.
Yeah.
So I think that maybe makes it a little more difficult.
It is, but if you've got forward-thinking leadership, they'll count that as a value as well.
I mean, retention, I think, would be a huge.
Oh, yeah.
I mean,
especially in a competitive market.
Yeah.
Yeah.
Okay, thank you.
Yeah.
Hey, excuse me. Hey, so you said something which was pretty interesting to me. How slow is your EMR? You said like 15 minutes to document in 10 minutes. Is that true? Is that really how it works?
Okay, so you gotta, don't light me up. So how slow is our EMR? Our EMR is like lightning fast. What are you talking about? So, so we have an agreement actually that if I click that screen, I better get something back in less than like 1.8 seconds, and that better happen like 97% of the time, or my vendor's gonna pay me a fine, right? So what I'm talking about is the workflow when I talk about the time. So since you hit on that, you know, when we educate our physicians in a really collaborative way about documentation, we've actually taken that 15 minutes to 3. We've reduced after-hours documentation by 57% for one of our departments. Inpatient, we've taken documentation time from 18 minutes to 90 seconds. If you're I know, God forbid we use the product as designed, but if you use the product as designed, it can dramatically increase the time spent doing the work. It has nothing to do with the actual, you know, clock speed of what's going on.
Cool.
Yeah.
You know, I would just say, you know, for us, it's speed. I mean, a lot of times we complain, you hear doctors talk about click, you know, how many clicks it takes to do something. And while it's sometimes easy just to laugh off, like, oh God, you clicked twice, the world's ending. But it is about also how you build those, you know, how can you make it better? How can you make it faster? How can you make it, it's not that it's super slow to click something twice, but is there a way that you can route two things together so you can get it done in one click and make your workflows better? And a lot of times I think that stems from, you know, they want to do the right thing. They want the system to work better, and it's how you enhance things. But we're the same way. We're pretty
Let's take
fast.
this one last question, and then there's
We'll
wine
go, please.
outside the door.
Yeah.
Yes, sir.
Hi, my name is Tony Balding. I'm from Kaiser in Colorado. And my question is, and I really like what you guys have laid out. It's pretty helpful in a lot of ways for what we do. My question is sort of on prioritization. So let's say you have, you know, on a given day, you know, it seems like we always have more projects brought to us than we can possibly do. So you have, you know, 5 people come in and one project saves money, the other one brings in more revenue, the next one, you know, is something that you have to do because of HEDIS or some other compliance issue, and the next one is a big, you know, membership growth, and one makes everybody happy and a better experience.
Right.
How do you, this is probably a way bigger question than right before wine, but how do you prioritize those when you send them out of the room and you say,
Oh, it's totally easy. It's like, how much money are you willing to give me? You pay me, I'll make it happen. No, I'm kidding. So, you know, we use the Praveen NATH scoring system, so you should look that up. It's something that Sharp Health System was using that I kind of saw that and said, wow, this is, because we had that very same question. Our CEO would ask, you know, do we have any kind of metrics around this? And so we try to use what's called the NATH scoring system that, you know, you're going to have weights to, is it a regulatory requirement? Is it a patient safety requirement? Is there huge revenue attached to it? Did the CEO tell you to go do it? Because, you know, you kind of work for them. So, I mean, you're going to weigh all of those things, and at least it gives you some idea of where to kind of start. And then you are going to have, again, it's like changing the tires on a fast-moving car. You're always going to have these demands that come up that are going to ask you, they're going to force you to say, do we stop what we're doing here to do this? Or are we almost done? So let's just go finish that, and then we'll start. And our former CEO, unfortunately, he moved to Portland, but he used to say, if you can't do anything else, can you just T-shirt size it for me? Is it like small, medium, large? Just give me an idea what the work's going to be. And sometimes that was enough for him to say, okay, I'll wait. So I would love to tell you that there's a single answer that works great. I would say whatever you do, if you develop some metrics around it, just stick to it, because it really helps the people who are suggesting projects when you say, this does sound great, but at the end of the day, that it's not going to have the impact that we've got to get these done. And the other thing that we've done is that my CIO and I, we actually do this traveling roadshow with the department chairs, because we're built on the foundation of the academic departments. And so we meet with the chairs at least once or twice a year to sit down and say, this is our entire list of projects. These are the ones we think apply to your department, and this is where they are. Does that resonate with you? And a lot of times they go, wow, I had no idea you had almost 200 active projects. I'm good. So you got to kind of work the floor a little bit too.
So what was that system called again, sorry?
So it's called the NATH scoring
NAT?
system. NATH. It's named after Praveen Nath. If you look under NATH scoring in Stanford, you'll probably find it out on the internet. It's got a nice PowerPoint presentation you kind of start with.
Okay.
Yes.
Yeah, same thing. Weighted is very important. And yeah, you have to have flexibility. Like I'll just give the example a couple years ago, when we were doing ICD 10, right? You big ramp up, then it got delayed. Big ramp up, delayed again. And so each time, like, oh, we can't do anything during this time frame, and then suddenly it gets delayed, and you're like, well, now we can take more back in, and it is, and it's part of it's a transparency. Like when I say we show our whole project approval list, it's a lot on there, and yeah, some stuff keeps maybe getting moved down. It's because you have to be flexible, and just because I approve something in January, now February's here, there's a new federal regulation, something else, it's going to get moved, but it's being transparent and having that flexibility, and I think the open communication is very important. But yeah, we weigh things. So if you've been on that project approval list for a long, let's say you scored an 89 last year and something this week came out and it was a 92, well, it's probably not fair to just automatically slide them right ahead of you because of the number. So there's a weighted average based on how many days and things like that to try to even things out.
Okay.
Well, thanks for hanging in there with us, guys. I hope you had a great time at HIMSS.
Go get drunk.
We sure had a pleasure closing out your last day, so have a great evening.